Hello my dear friends, once again welcome to Medicomello. This time we are going to see the topic acid-base metabolism, the acid-base balance in our body. This acid-base balance or homeostasis is very important for the normal physiology of human body. And as we all know that there are many buffers in the body, in the blood, that acts in regulating the pH. The normal pH is around 7.40 and the range is actually 7.35 to 7.43. And if any of this is varying, then these buffers act and regulate the pH and correct it to the normal value. Here we have to remember this equation. The carbon dioxide, which is an acid, combines with water to give the carbonic acid, which is a weaker acid, and it shifts to right, releasing the H+, which is an acid. The highest acidic nature is given by this H+, along with release of bicarbonate. It is basic. Now we have to be familiar with three main mechanisms in buffering this pH. Initially, the chemical buffers, which are the immediate buffers. Secondly, the respiratory system, they are involved in acute action. Then thirdly, the renal system, which is a little bit slower in action. The chemical buffers involves first one, the bicarbonate and the carbonic acid, HCO3 minus and H2CO3, which is the main important one. Secondly, the proteins. Thirdly, the phosphate buffer, and finally the sulfate buffer. The respiratory system, there are two possibilities. The first possibility, if the blood pH is very lesser, which means it is acidic in nature, it stimulates the respiratory system, causing hyperventilation. And this hyperventilation washes out this carbon dioxide. And what happens then? This partial pressure of carbon dioxide decreases. And as I have told you before, this carbon dioxide is acidic in nature. Then as a result of reduced partial pressure of carbon dioxide, the acidity decreases. And this is the mechanism involved in the respiratory system following reduced blood pH or acidity in the blood. Then what happens if the blood pH is higher, that is when the blood is alkaline in nature, then it in turn inhibits the respiratory centers, causing hypoventilation, reducing the frequency and depth of the respiration, and this causes the carbon dioxide retention. And as a result of the carbon dioxide retention, what happens? This partial pressure of carbon dioxide increases. Carbon dioxide is acidic in nature. As this carbon dioxide accumulates, the alkalinity decreases or it becomes more acidic. And these are the mechanism involved in the respiratory system. Let's look out the mechanism involved in the renal system. I have told you it is slower in action. What is happening there? Bicarbonate resorption occurs at the proximal tubule. Hydrogen ion excretion occurs in the distal tubules, and also ammonia NH3 excretion occurs at the proximal convoluted tubules. These three are the mechanism involved in the renal system. Let's get more deeper. Regarding the chemical buffers, the bicarbonate buffer, this is the equation. HCO3 minus plus H plus combines to give H2CO3. And if this pH of the blood is lesser, which means the blood is more acidic, then it shifts to the right. Why? Bicarbonate combines with this acidic natured H plus to give a much weaker acid H2CO3. So this acidic, more acidic H plus is being converted to H2CO3, which is a much weaker acid. Thus we are able to decrease the acidity in the blood. And what happens if the pH is very high? That is, what happens? The blood is more alkaline. Then this equation shifts to left, which means this bicarbonic acid get converted to H plus and bicarbonate ion, releasing the more acidic H plus proton, and thus the acidity increases and thus improving this in pH, correcting the alkalinity. The second important thing is proteins. These proteins bind with H plus or Ca plus, that is a proton, hydrogen ion or the calcium ion. If the pH is lesser, which means if the blood is acidic, then the proteins tend to bind with H plus and thus increases the pH or decreases the acidity. That is, by combining this protein with H plus, this protein neutralizes this acidic H plus by combining with it, and thus it reduces the acidity and increasing the pH more to the alkaline side. Just opposite to this, if the pH is very high, which means if the blood is more alkaline in nature, then the protein binds with calcium ion, it neutralizes the calcium ion and thus decreasing the alkalinity and decreases the pH, shifting more to the acidic nature. These are the roles of the proteins. Regarding the phosphate buffer, which are more potent, why it is more potent? This single phosphate molecule is able to combine with 3 such protons and thus neutralizing to H3PO4, which is a much lesser acid. Now we can say that if the pH is lesser, which means the blood is more acidic, then this equation shifts to right, combining 3H plus, neutralizing these 3 acidic H plus to give H3PO4, decreasing the acidity or converting it to more alkaline nature. And this is the same happening in the sulfate buffer also. And this is all about the chemical buffers. The respiratory buffers we have seen initially, and now the third one, the renal system. In the renal system, we have discussed before, there is reabsorption of bicarbonate ion, there is excretion of ammonia, and also excretion of H plus protons. This is the bloodstream and this is the lumen. Lumen means where the urine is being drained here. And this is the proximal tubule and this is the distal tubule. So in this proximal tubule, the bicarbonate is being reabsorbed from the urine, from the lumen into the proximal tubule and then into the blood. Whereas the ammonia ions are being sent or excreted into the lumen and is excreted through the urine. Whereas in the distal tubule, the protons H plus are being taken from the bloodstream and then excreted into the lumen through the urine out of the body. How? This H plus is combined with ammonia to form ammonium ions, and these ammonium ions cannot be reabsorbed or it won't dissociate back into H plus or NH3. So thus it effectively removes the H plus being excreted into the lumen. And this is what is happening in the renal system. So assume a situation where the blood pH is lesser, which means the blood is more acidic. So what we have to do, or what the body must do, it has to reabsorb the bicarbonate to increase the alkaline nature in the blood, whereas it has to excrete or secrete out the H plus, which is the reason for the acidity in the blood, and that has to be excreted out into the urine out of the body. So that is written here. Increased more amount of H plus has to be excreted into the urine. That is what is happening here. It is being excreted out. And increased bicarbonate ion reabsorption into the blood. Yes, that is what is happening here. It is reabsorbed back into the blood. So this coming back into the blood gives more alkaline nature, whereas this proton being sent out of the blood may decrease the acidity in the blood. This is what is happening in the renal system to maintain the blood pH. Next, what are the acid-base disorders? We have to understand the concept of the acid-base metabolism, the balance between them. If this acidity increases, then the body will be showing features of acidosis, whereas the base in the body, in the blood increase, then the body will be showing features of alkalosis. The pH range, I have told you before, it is between 7.35 to 7.43. If it is lesser than 7.35, then it is acidic in nature. The body will be having features of acidosis. Whereas if it is more than 7.43, then more amount of base are present in the body, showing alkalosis features. And on an average, the normal pH is 7.4. So let's look out which are the acid-base disorders. First one is the most important one, the metabolic acidosis. This metabolic acidosis are of two types: high anion gap metabolic acidosis. Second one is non-anion gap metabolic acidosis. Initially, there are two formulas or equations to derive the anion gap. The first one is A. Anion gap is equal to unmeasured anions minus unmeasured cations. Anions means those compounds or products which are having negative charge. Cations are those with positive charge. And this unmeasured anions, examples are lactic acid, acetic acid, salicylate, formate, oxalate, sulfate, phosphate, proteins, etc. Whereas the unmeasured cations are potassium, calcium, magnesium, lithium, etc. And this difference in their charges are giving rise to this anion gap. So how this high anion gap comes? There can be two possibilities again. High anion gap comes if there is high or large number of unmeasured anion, that is this part, if this is very large, or if it is very small amount of unmeasured cation, or this unmeasured cation, this subtracting part, if it is lesser, small, then again this anion gap will be higher. And the second equation or formula is anion gap is sodium ion minus chloride ion plus bicarbonate ion. This chloride with bicarbonate ion has to be subtracted from sodium ion, and this equation is being derived from the first equation. From this we can derive the non-anion gap. How? What is this non-anion gap? Bicarbonate loss is the cause of non-anion gap. This bicarbonate loss itself causes acidosis, that we know, because bicarbonate is the agent that maintains the alkaline nature in the blood. So if it is lost, it causes acidosis. But this bicarbonate loss is associated with a compensatory increase in the chloride concentration. This is for an electrical neutralization, to balance the charge in the cell. So this chloride ion increases along with the bicarbonate loss. So this balances this anion gap. How? Look at this equation. Here this bicarbonate is being reduced. It is lesser, but there is compensatory increase in the chloride concentration. So this part again increases. So as a whole, this Cl minus plus HCl3 minus is around stable, is around the same. So when we are decreasing it from the sodium ion, then this anion gap will be around the same. There won't be much difference. So that is known as this non-anion gap. If the sodium is very high and if this chloride plus bicarbonate ion concentration is less, then there comes this gap. A very large difference comes in between them, and that again gives rise to high anion gap. But here it is non-anion gap. So that is this mechanism behind it. So this compensatory increase in the chloride concentration along with the bicarbonate loss causing the acidosis is known as hyperchloremic acidosis. Let's look at the examples of high anion gap metabolic acidosis. Most commonly, it is due to endogenous acid load. which are the endogenous acids, mainly lactic acidosis, diabetic ketoacidosis, in the starvation ketoacidosis due to alcoholic ketoacidosis, and salicylic acid overdoses. These are the examples or causes of high anion gap metabolic acidosis. Getting more deeper, in case of lactic acidosis, there can be two types, type A lactic acidosis and type B lactic acidosis. Type A lactic acidosis is the most familiar for us. It is due to anaerobic respiration. It is due to increased synthesis of lactate. And why it is so? It is seen at hypovolemia or decreased cardiac output or decreased perfusion of the cells by the oxygen or by the blood. So as a result, anaerobic respiration occurs and more amount of lactic acid synthesized. Regarding the type B lactic acidosis, it is seen in aerobic respiration. Then why it is occurring? It is due to reduced excretion or decreased catabolism, breakdown of the lactic acid from the body. Why? It is seen at liver or renal failure or when that patient is being treated with some drugs which inhibits the excretion or removal of the lactic acid from the body. And these are the examples of high anion gap metabolic acidosis. Next, examples of non-anion gap metabolic acidosis. As we have discussed before, it is caused by bicarbonate loss with compensatory chloride increase. Mainly, it is associated with GIT loss like diarrhea and also sometimes due to ingestion of inorganic acids. In diarrhea, there is bicarbonate loss along with water and loose stools. The second cause is regarding the renal system. It is renal tubular acidosis RTA. Why it is occurring? It can be of three types. First one, proximal renal tubular acidosis. It is the type 2 renal tubular acidosis. Why? What is happening there? There is impaired bicarbonate reabsorption. So due to this impaired bicarbonate reabsorption, the alkaline nature of the blood is suppressed. Thus, it becomes more acidic in nature. Second, type 2 is classical distal renal tubular acidosis, and that is the type 1 renal tubular acidosis. What is happening there? There is impaired proton secretion. This proton, which is the cause for increased acidic nature of the blood, that is unable to get excreted, removed from the body. So it accumulates in the blood and causes this acidosis, and that is the classical distal renal tubular acidosis. And the third one is hyperkalemic distal renal tubular acidosis, and that is the type 4 renal tubular acidosis. Type 4. What is happening there? There is impaired sodium reabsorption. Why? Because the concentration of this potassium is very high in the blood. So there is impaired sodium reabsorption. The sodium and the potassium are just acting opposite. They are like enemies. If one concentration is tending to be more higher, then the body tries to decrease the other one's concentration. If sodium is reabsorbed into the blood, then the body tries to remove the potassium out of the body. And that's about the metabolic acidosis. And the second one, metabolic alkalosis. The more amount of bases or alkali is present and causing the metabolic alkalosis. The most common cause is hypovolemic metabolic alkalosis due to vomiting. And this vomiting induced hypovolemic metabolic alkalosis is chloride responsive type of metabolic alkalosis. Obviously, there is another type, chloride unresponsive type. So here, due to hypovolemia, decreased blood water levels causes this alkalosis. So if we are supplementing, giving chloride ions, then it responds well. We can treat the disease, and that's why it is chloride responsive, whereas this chloride supplementation is not effective in chloride unresponsive type, where the cause being increased aldosterone action. How this aldosterone acts? This aldosterone acts at the epithelial sodium channels. It is a channel between the lumen in the renal system and the blood in the kidneys. So what is happening there? By stimulating these epithelial sodium channels, this aldosterone acts and it reabsorbs the sodium from the urine or the lumen back into the blood, and thus the concentration of the sodium in the blood increases. At the same time, I have told you before, the sodium and potassium are like enemies. So at the same time, the potassium is being sent out of the blood into the lumen and excreted into the urine out of the body. To maintain the electrical neutrality, protons H+ are also being sent out of the body, excreted out into the urine. So what is happening there? This H+ is the main source of acidic nature in the blood. So what happens if it is sent out of the blood? Then the blood's acidity decreases. Then the blood becomes more alkaline in nature, and that is causing this alkalosis, metabolic alkalosis. And that is happening in chloride unresponsive due to the increased action of the aldosterone. Next, we have to look the main cause of this metabolic alkalosis due to vomiting. What happens in vomiting? This is a flow chart given in Davidson's textbook of medicine. Mainly gastric acid HCl loss. This acid loss obviously it causes metabolic alkalosis. Second one is due to vomiting there is loss of sodium chloride. So the sodium as well as the chloride ions are lost, and this causes hypovolemia, decreased blood water content. It stimulates the reabsorption of sodium and the bicarbonate ions, and this bicarbonate ion, when it is reabsorbed, its concentration in the blood increases. It causes alkalosis, metabolic alkalosis, and this hypovolemia also stimulates renin-angiotensin-aldosterone system. Mainly the aldosterone is being released. And what is the function of aldosterone? It causes sodium reabsorption, potassium excretion. Along with that, there is H+ excretion that we have seen in the previous figure. Due to vomiting, there is potassium chloride loss. As a result, there is hypokalemia, reduced concentration of blood potassium levels. And from this, the potassium excretion due to activation of aldosterone system, it again worsens this hypokalemia. And this hypokalemia itself stimulates this H+ excretion. And in both the ways, this H+ is excreted, and as a result of excretion of the H+, which is the main acidic agent of the blood, as a result of its removal from the body, it causes metabolic alkalosis. So from three main ways, from the loss of the gastric acid, directly it causes metabolic alkalosis. Due to hypovolemia, the sodium and bicarbonate reabsorption, it causes metabolic alkalosis. Due to potassium excretion activated in two other ways, it causes this metabolic alkalosis. And this is the mechanism of action of metabolic alkalosis due to vomiting. And next is respiratory acidosis. Acidosis due to respiratory cause. Why? It is mainly due to hyperventilation, reduced rate, frequency and depth of respiration. And what happens? There accumulates this carbon dioxide and it increases the partial pressure of carbon dioxide in the blood. Remember, carbon dioxide is acidic in nature. So as a result of accumulation of carbon dioxide, it increases the acidity of the blood, causing acidosis. And as it is due to reduced respiratory rate, it is known as respiratory acidosis. So it can be due to any respiratory center lesions in the pons, medulla, etc. It can be due to lesions in the nerve, neuromuscular junction, in the respiratory muscles, in the chest walls, etc. And it can also be due to chronic airway diseases like COPD. Somehow the body has to compensate this thing. So what is the compensatory mechanism? The body increases the bicarbonate reabsorption by the kidneys. This bicarbonate, when it is more reabsorbed, its concentration in the blood increases. This bicarbonate ion, which is the main agent of alkaline nature in the blood, increases the alkalinity in the blood, decreases the acidity, and thus compensates this respiratory acidosis. And this equation we have to remember again. As this carbon dioxide concentration increases, we have to shift it to the right. That's why this bicarbonate ion reabsorption we have to increase. In this figure also, here the carbon dioxide level is very high in the body. If we want to balance or keep these at the same level, we have to increase this bicarbonate level here. So how? By reabsorption from the kidneys. And that is what is happening in the compensatory mechanism. Just opposite to that, there is respiratory alkalosis. The alkaline or basic nature of the blood is increased. Why? Just opposite to that, hyperventilation, very rapid and deeper respiration causes washout of the carbon dioxide and thus decreasing the partial pressure of carbon dioxide, and thus carbon dioxide being acidic in nature, while it is being washed out, it causes reduced acidity in the blood, which means alkalosis. And as it is due to increased respiratory rate and depth, it is known as respiratory alkalosis. What are the causes? Mainly drugs like salicylate. Due to anxiety, when we are anxious, we breathe rapidly and much deeper. Infections like meningitis, sepsis, etc. In fever. Fever causes increased respiratory rate, and that causes washout of the carbon dioxide. The mediators are cytokines like interleukin 1 and 6. And in case of reduced alveolar filling due to pulmonary edema, pneumonia, etc. So this reduced filling causes hypoxia. This hypoxia activates the respiratory center to increase the respiratory rate, causes hyperventilation, and washes out this carbon dioxide. Somehow the body has to compensate this. What is being done? The compensatory mechanism is just opposite to the respiratory acidosis. Here we have to reduce this bicarbonate reabsorption from the kidneys. Yes, bicarbonate is the agent of alkalinity in the blood. So if we are decreasing its reabsorption, then we can increase the acidic nature by decreasing the alkaline nature in the blood. And that is how the respiratory alkalosis is being compensated. Summary, we have to sum it up. There are four main things: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. What is happening in metabolic acidosis? It is due to endogenous acid load, or it can be due to bicarbonate loss, where endogenous acid load is causing high anion gap metabolic acidosis, whereas bicarbonate loss is the cause for non-anion gap metabolic acidosis. What is the compensatory mechanism? By hyperventilation. By increased ventilation, it washes out the carbon dioxide concentration in the blood, decreasing the partial pressure of carbon dioxide, and thus increasing the alkaline nature in the blood, decreasing the acidity. And that is the compensatory mechanism by the respiratory system. And second one is metabolic alkalosis. It is mainly due to vomiting. How? Due to the gastric acid HCl loss, due to bicarbonate reabsorption, and also by H+ excretion, and also by increased aldosterone action, which is the cause for chloride unresponsive metabolic alkalosis. how it is compensated by the respiratory system itself, how hypoventilation, decreasing the respiratory rate and the depth, and thus increasing the carbon dioxide concentration and increasing the acidic nature of the blood. And what if the problem is by the respiratory centers? Yes, respiratory acidosis. It is due to hypoventilation, and it increases the partial pressure of carbon dioxide. How the body is compensated? It is compensated by the kidneys by increasing the bicarbonate reabsorption. And what about the respiratory alkalosis? It is due to hyperventilation. It decreases the partial pressure of carbon dioxide. How the body is compensating it? By decreasing the bicarbonate reabsorption, and that even by the kidneys. So from this we get an idea. If the cause is metabolic by renal system or by the chemical buffers, it is being compensated by the respiratory system. See, that is happening in the metabolic acidosis as well as the alkalosis, where the respiratory system is the compensatory mechanism. Whereas if the problem is by the respiratory system itself, then the kidneys come into play. The kidney buffers helps in the compensation, and thus the problem, the issue caused by this respiratory centers like the acidosis and the alkalosis are being corrected by the kidneys. And thus we come to end of our topic, acid-base metabolism, reassuring you to be in the top 1%. You have to be willing to do what the 99% aren't. This is your Medico Mallu. Thanks for watching this video. Please like, share and subscribe.